Hello everyone. Today's session is going to be about ACLS guideline regarding the adult tachycardia. In last sessions, we have discussed about atrial fibrillation. We have discussed about adult cardiac arrest, pulseless electrical activity. We have discussed all these approaches that we do in USMLE exam, and whenever we have a real life scenario when we are working in ER or anywhere, we have to keep these things in mind. So today we'll be discussing the ACLS guidelines regarding adult tachycardia. So first of all, you have to determine, obviously by looking at the ECG, what sort of disorder the patient have. We will have the history of palpitations, we will have the history of maybe the chest pain, and then we have the patient who presents in the emergency ER, and then we do his uh, ABCs, we give him IV. We put him on IV line, we put him on oxygen, and then we do the ECG, and then we get arrhythmias. Now you have to determine whether the patient is hemodynamically unstable or stable. So first thing is to determine the hemodynamic status. If he's hemodynamically unstable, we have to treat it promptly. We'll go for synchronized cardioversion. Why synchronized? Because patient is living, and these type of tachycardias, we only do unsynchronized cardioversion or defibrillation in ventricular tachycardia or ventricular fibrillation. Whenever there are other sorts of tachycardia, then we do synchronized cardioversion. The reason being for that is that whenever we put the patient or we cardiovert the patient, it can lead to arrhythmia. So we have to be very careful that it is synchronized. We have to match the synchronization. I think I have to talk to somebody. I'm sorry, I have to go and talk to somebody. So the thing is that we were talking about the arrhythmias and tachycardias, and whenever the patient is having uh, the patient is right now to you with hemodynamically instability, and he has tachycardia, then we go for synchronized cardioversion. If the patient is hemodynamically stable, or he just have sinus tachycardia, then we have to treat the underlying causes. It could be fever, it could be hypothyroidism, it could be anything else. Go for the underlying cause if there is no arrhythmia. If there are arrhythmias, then we have to go further deep into that. We have to go further deep into the flowcharts. So the patient is hemodynamically stable. He doesn't have sinus tachy. Now we go move to the next step, which is to look at the QRS interval. The QRS interval is really important. If the QRS interval is wide, the management is different. If the QRS interval is narrow, the management would be different. So the patient presents with wider QRS interval, then the next step would be to look at the rhythm. if the rhythm is regular or irregular. White QRS, regular rhythm, it's monomorphic ventricular tachycardia. Its management is basically we have to consult cardiologist, the expert. We have to get the expert consultation, and we have to obviously treat the patient. We have to pharmacologically cardiovert the patient, and that would be procainamide. We can use type 3 amiodarone. We can use lidocaine, type 1B. We can use sotalol. So these are pharmacological measures we can use. If and now the next step, the patient has white QRS and irregular rhythm. Then this could be they could these could be three things. You have to look at the ECG. You have to determine whether it is pre-excited atrial fibrillation, whether it is atrial fibrillation with aberrancy, or whether it is we can say ventricular tachycardia. So if it is pre-excited atrial fibrillation, or we can say it could be polymorphic ventricular tachycardia, yeah. White QRS, irregular rhythm. It could be polymorphic ventricular tachycardia, it could be atrial fibrillation with aberrancy or pre-excited AF. So for pre-excited AFib, go for the rate control measures, beta blockers, calcium channel blockers. For the atrial fibrillation with aberrancy, go for procainamide, and for polymorphic ventricular tachycardia, go for magnesium. Now the next step, if the patient has narrow QRS, again the next step would be the same. Go for the rhythm. If the rhythm is regular or irregular. Narrow QRS, regular rhythm, it's definitely atrioventricular nodal re-entrant tachycardia. So that is basically treated with the vagal maneuvers. We can have to give massage to we can do the carotid massage, we can do the vagal maneuver. The next step would be adenosine. And if the patient has narrow QRS and uh, irregular rhythm, that's AFib, and that's treated differently. We have to give rate control, rhythm control, or we have to cardiovert the patient if he has the new onset AFib and presents within 48 hours and has no other structural heart disease. If it's more than 48 hours, he has valvular disease, go for echo, then cardiovert. If he doesn't have thrombus, if he has thrombus, anticoagulate him with warfarin for 3 months, then cardiovert him. Definitely, then the most specific treatment would be catheter ablation. So this is the basic map or flow chart or management for the patient who has adult tachycardia, presents in the ER, and he gets this sort of management. So we have already discussed AFib in detail in previous videos, and we have discussed adult tachycardia or cardiac arrest with or pulse electrical activity in the another session. So in next session, we'll be discussing some other arrhythmias, and if you have any question, you can type these questions in the comment box, and any suggestions are welcome. And I'm thinking to share the some ECGs, important ECGs in next sessions through share screen options. I have just discovered it. So thank you for today's session.